Thank you very much, Professor Galia Auron, for your excellent presentation. And we proceed to the next speaker, who is Professor Michael von Wolff, who is the head of the Department of Gynecological Endocrinology and Reproductive Medicine at the University Hospital in Bern in Switzerland. He's going to give a talk about the indications for and against fertility preservation. Professor.
Yes, thank you very much for this nice introduction. I never gave a speech as a last person of a meeting, and I think it's probably the best needs to be kept to the end. Now, let's talk about this topic, and I was asked to talk about indication for and against fertility preservation. We just heard a presentation about kind of social freezing, non-medical freezing, and now it's about medical freezing. So it's the other side. What I'm going to do is I give you a short introduction. I give you a very short overview of the measures to protect fertility, only 4 slides because it's not my presentation. And the options to estimate gonadotoxicity, that's what I'm going to tell you then, and then I give you a short summary. What I think is many in this room might not be involved in medical freezing, which is quite complex, seeing all these cancer patients, but most of people and gynecologists are involved in seeing patients and making the indication or to do fertility preservation or not to do fertility preservation. And therefore, I think it's important to know what the indications are or where you can retrieve the information from to do this indication. So the introduction. Medicine should follow a logical order. First, the indication, and then the intervention. I'm sure we all agree. Regarding this topic, it means if you have a patient with a chemotherapy or cancer treatment with a high degree of gonadotoxicity, then of course that's the indication for an intervention, meaning medical freezing. And if there's a low degree of gonadotoxicity, then the indication is not to do an intervention, rather to go for a wait and see, and maybe to do something after the cancer therapy. Quite understandable. However, especially in females, we do not always proceed according to this logical order. And one of the reasons is the order needs to be based on reliable prognostic data regarding gonadotoxicity and the risk of infertility. However, data are very limited for several cancer diseases, especially for those which are not that common and for new cancer therapies. We do have different indications for or against cancer therapy, fertility preservation. As you can see in white, these white boxes are all indications to do something, meaning if the patient is less than 40 years old, patients will probably survive. Then in the females, the pregnancy should be compatible with the health of the woman, and fertility preservation can be performed with low risk for the health of the patient. But the most important criteria is certainly the moderate or high risk of therapy-induced infertility, might be more than 20%. In these cases, if all these 6 criteria are fulfilled, then you can go to the downwards to the lowest line and go for fertility preservation. And if not, then you should not do anything. When you talk about this topic, then we should we should think of the diseases which we probably have to deal with. And these are the number of the Fertility Protect network for Germany, Austria, Switzerland the last 10 years. But it's always the same all over the world, and about almost 50% of the patients are breast cancer patients, about 25% of patients are Hodgkin lymphoma patients, and the most interesting patients here are the other 25% of patients with sarcoma, bone cancer, gastrointestinal tumors, etc., from which we do not have many data. Let's briefly look at the different techniques which are available and which are mainly performed in the infertility centers. You know, we tend to give GnRH agonists or maybe GnRH antagonists now because they are now on the market. And one of the very last meta-analysis, a good meta-analysis, this one from 2022, and we do know, yes, these meta-analysis only includes RCTs of breast cancer patients, and we do know that GnRH agonists increase the chance to resume a menstruation, so to stay fertile by the factor of 3. But of course, this is only for breast cancer patients, and it only tells us something about a follow-up of 1 to 2 years. We have no any data regarding a long follow-up, and we have no any data regarding other patients like bone cancer, sarcoma, etc., etc. The second technique we do know is ovarian stimulation. It's full established. We all know how to do this. You can do random start stimulation. You can do a double stimulation. You can do progestin primed ovarian stimulation. It works very well, and we already heard about it. Social freezing is done the same as equally. And the third one is ovarian tissue cryopreservation. It is also established now, not performed in all countries, but in these 30 protect countries, it's done quite a lot. And we know that 50% of patients can get pregnant spontaneously after the transplantation of the tissue. And we even are able now to calculate the live birth rate based on the age of the woman when the tissue is frozen. So these are the main technologies. And when I summarize it, what I just did to find out or to see or to describe the success, the overall success rate, then you can see in the top, as I said, GnRH agonists seem to increase the chance to stay fertile by a factor of 3. Oocytes, embryos, the overall live birth rate after a freezing process is 30%. Ovarian tissue, it's 27% based on a meta-analysis, and for sperm, it's 49%. So it's quite similar, by the way, oocytes freezing and ovarian tissue freezing. But here on the right-hand side, you see the number of patients who delivered a baby based on the number of freezing processes, freezing procedures. And regarding oocytes, you see it's 2.8%. Regarding tissue, you see it's 3.7%. Regarding sperm, it's 4.4%. So it's less than 5%, meaning that you have to do a laparoscopy to take tissue out. You have an ovarian stimulation to collect oocytes in at least 20 women to get 1 live birth. So the number needed to treat is very bad, meaning we need to have these strict indications, otherwise we're doing more harm than good. So, as I said, we need strict indications for, but also against fertility preservation, and these indications should mainly be based on the risk of gonadotoxicity. And what I'm going to do now is I show you the options where you can retrieve this information to decide which patient should undergo fertility preservation and which one should rather not undergo fertility preservation. I have chosen 4 different options. I think you should need all of these options at some stages, and I should go through it and I tell you where you get the information from. The first one is tables in the literature. This is published, and you can see, like in this paper from 2023, which tells you all the different chemotherapeutic agents, and it tells you how gonadotoxic they are, high risk, intermediate, very low risk. You can find next tables in the same papers, and yes, other medication, other chemotherapeutic agents, and you find even combination of therapies, so you get quite a lot of information from these lists which have been already published. But of course, these tables do have some strength and also some weaknesses. So they give you a good overview about the toxicity of single agents, and they're easy to use. Just download them, use them. However, the weaknesses are substantial. There are hardly any data on the gonadotoxicity related to dosage. You know, cyclophosphamide at low dosage doesn't matter. At a high dosage, it matters very much. Hardly any data on the gonadotoxicity related to female age. We know, young women doesn't matter that much. Old women, it matters much, much more. And there's very limited information on protocols which combine several agents, which is also very important. So there are substantial weaknesses, but still they give you some guidelines, some idea which medication might be a problem or which might not be a problem. The second one are the online calculators, which are quite interesting. And I have two online calculators to present here. The first one is the CRISP online calculator. You can get it when you go on www.oncofertilityrisk.com. It's a cancer-related infertility score predictor. And it's quite interesting. And when you go on this calculator, then you just add, for example, I did it on the left side, you add, it's for females, you add a patient saying she has a sarcoma, and then you add the age, 30 years, and then you hopefully know which protocol she get, VDC, and then you add all this, and then you get a risk of infertility of 10 to 20%, so which is nice. Easy, simple, but of course you have to be very careful, because the question is, what is the underlying study which is used to create this number? And you can go into depth and try to find these studies, but it's very limited data, and you have to be very careful, because it sounds very accurate, but it is not that accurate as it appears to be. And if you have another patient like with brain cancer, you don't get any information, so meaning that, of course, this online calculator has some limitations, because it's not open for all kinds of diseases. There's another online calculator which I think is a fantastic one. It's a CED calculator, but it's only for children. It's a cyclophosphamide equivalent dose calculator, because we know that cyclophosphamide is gonadotoxic, and this calculator twice, and you have to add the different medications the patient gets, the different dosages, and then it gives you a number. And this number then tells you whether it's a low, medium, or high risk. And it had been evaluated and validated by Isabel de Mestere and presented at ESHRE, and I found it so great, that's why I'm showing you. And she has a cohort of young patients, and she separated into different groups, low risk group, medium group, high risk group, according to the calculator. And what you can see below is the first group, from the cancer therapy to the follow-up of 3 years, AMH stayed the same. So low risk was a really low risk. Medium risk, AMH went a little bit down, or was up and down. And high risk, really AMH went down. So this seems to be a quite valuable online calculator to be used. So the strength of these online calculators is CRISP, the first one. It's very easy to use. It can be used for different chemotherapy regimes, and it provides female age-related data, but there are some weaknesses. The accuracy is based on mostly limited data. They cannot be more accurate than the data are available, and they're not that many. The accuracy is difficult to estimate, because you just get a number and you don't know how real this is. The toxicity rather based on mean values but not ranges. It's very important. I mean, we know that people respond differently to chemotherapies. Some people might have a low risk, others might have a high risk, so it should be a kind of confidence intervals, and then you can decide whether you go for the worst expected case or for the best expected case, but that's what they do not provide. CRISP is only for females. CRISP is not for all therapies available, and the CED calculator means you need to know the exact dosage of the treatment, which you usually do not know, and you don't know what kind of other therapies might follow after the first chemotherapy cycles. The third one is the reviews of the literature and the meta-analyses, and that's what we have done. I just show you what came out. What is Fertitox? It's a project which had been initiated 2023, and it has two kind of study arms. Yes, it's a kind of retrospective arm in which we analyze the whole world literature regarding the prescribed gonadotoxicity of different diseases, and wrote this meta-analysis, which are almost finished. And then the prospective analysis when we include all these patients, Germany, Austria, Switzerland, measure in all these patients, in female patient AMH before and after cancer therapy, and in male sperm concentrations. And we did already almost finish these meta-analyses. We have done 9 so far. The last one will be finished from leukemia. We finished in summer. And you can get all this information regarding the prevalences of infertility or assumed infertility, the risk of infertility of all these different diseases. It's just a range. When you go on the website, you see even the confidence intervals, and then you get an idea how toxic the therapies are. And you find this on this website. It's www.fertilitox.com, and you just go on published paper or on the red banner, which is not shown on this slide. Just click on it, and then you get all these information. It's very easy to get described the same way, only access papers. So there are strengths of this kind of instrument. It's easy to use. Just go on the website. It includes confidence intervals of the risk of infertility, so the worst possible case, the best possible case, based on very large data sets. It's all from 2024 to 2025. So 20 years of published data, and all reviews are written in a similar style, which makes it easy to compare these studies. But of course, there are also weaknesses. Mostly we pooled protocols, and you know a meta-analysis means pooling data. So we pooled protocols, and we were not able to analyze the protocols separately. It's based on studies published since 2000, which is great, but only till now. So all the new therapies, checkpoint inhibitors, etc., are not included. So it's another instrument, but it gives you another look at it from a different angle. And I think if you look at all these, we take all these instruments, then you might get a good idea how toxic these therapies are. Now let's look at the prospective cohort data instrument, and that's part of Fertilitox. And what we're doing, as I just said, we're analyzing AMH, our sperm count before and after chemotherapy, and then a follow-up after 5 and 10 years. And we're not only doing this, what we also do in these 3 countries, we also ask for the fertility preservation measures performed, what are the complications, what was the satisfaction with or without not doing this fertility preservation procedure, what was the efficacy of the fertility preservation, and was the natural fertility and the fertility based on the fertility preservation procedure. So hopefully we get more information. The strength of this last instrument is, yes, it includes new agents. So that's great. The data will be very precise because it's based on AMH concentration, but the weaknesses is no data yet because we just started, and other countries also just started. So there are hardly any data yet. Studies are ongoing. We expect the first data in 2026 for the main diseases like breast cancer, testicular cancer, and Hodgkin's lymphoma, but for osteosarcoma, etc., it will take another 1 to 2 years. What I just want to tell you is I'm so happy that this topic is not only not only us who thought that it's an important topic, that even the European community thought that this is a very important topic to sharpen the indication for against fertility preservation. It's a huge program set up by the European community, the Horizon program. There are 2 different situations I would like to focus on, and then I'm finished with my presentation. The first one are children. And with children, I find it very difficult because I found it very difficult to say, is a child 8 years old takes the ovary out? I mean, it's a semi-castration, and is it really necessary? And when you look at these data, and these are very good data, and just onto the left side, then you see the blue curve. And the blue curves means children who got alkylating agents, chemotherapy for cancer disease, and the blue curve tells you how many children still had a menstruation regarding to age. And then you see that at the age of 30, most young adults still, after cancer therapy as a child or an adolescent, still had their menstruation, were still fertile. So I think in these cases in children, we do not do too much, and we should leave the poor children. We shouldn't take that many ovaries out. We can still wait and do something after the cancer therapy. And that children are not that sensitive is also part of one of these meta-analyses. In Hodgkin's lymphoma, we analyzed children, and what you can see, the risk of becoming infertile of children, adolescents in Hodgkin's lymphoma is only 8%, so the risk is very low, and we do not need to do that much in children. So I think one of the concepts we have to go for is that, of course, we should not only focus on fertility preservation just before cancer therapy, we should also focus on fertility preservation after cancer therapy, maybe in children only in these cases. It can be done 1 year after the chemotherapy when you can evaluate AMH concentration and you can interpret AMH concentration. And depending on what you get at this stage, then you decide to go for fertility preservation or you do not go for fertility preservation if the ovarian reserve is fine, or if it's very bad, you go for menopause care management, which is also a topic, and some children and young adults are left alone with this topic. So it's a kind of, we call it second stop, secondary fertility preservation approach. The last and second and last topic is what to do with all the new immune therapies, checkpoint inhibitors. There are 2 studies around with mice, and the first one was published in 2022, and these mice got checkpoint inhibitors, and then it was analyzed the ovarian density, the density of the number of follicles in these ovaries after 21 days, and it was substantially decreased. But of course, after 21 days, after 3 weeks, it was still a kind of inflammatory situation, so possibly it was due to this kind of inflammatory status, so the group waited for some more time, and after 100 days, when all the inflammatory response had settled, still the follicle number was decreased. So this very first study said, yes, checkpoint inhibitors seem to reduce the ovarian reserve. But there was a second study published in 2024, which didn't show anything like that. You have a control group in orange, you see the height of this column, and all the treatment groups had the same AMH level in these mice. So this study said, no, checkpoint inhibitors do not do any harm to the ovaries. So data are too limited to draw any conclusion, and today I checked again. There is no data around regarding humans, only case reports, so we have no idea whether this also applies to humans or not. We have no idea whether checkpoint inhibitors are a problem or not. So I come to the summary. Summary is fertility preservation measures have been established and can be offered to most cancer patients. Indications for performing fertility preservation measures are not precisely defined. Indications should be based especially on the risk of infertility and therefore on the gonadotoxicity of the treatments. Several options are already available for estimating gonadotoxicity, all with strengths and weaknesses. However, as none of these options are very precise and do not include new cancer therapies, first several options should be used to estimate gonadotoxicity, and the results of the prospective studies need to be awaited. Thank you very much.